Welcome to another episode of This Week in Pulmonary and Critical Care Medicine. I'm your host, and I'm excited to bring you a curated roundup of high-impact studies fresh from the literature that could influence how we manage our patients at the bedside. This podcast is designed with busy clinicians in mind. We sift through the evidence so you don't have to. Just a quick reminder before we begin, the information discussed in this podcast is intended for educational purposes only and should not replace clinical judgment. Every week, I aim to review a few original research articles and cap it off with one review article that offers a broader perspective. In this week's episode, we'll tackle a network meta-analysis comparing preoxygenation strategies in the ICU, a comprehensive safety review of biologics for asthma in children and adolescents populations, a new study linking SGLT2 inhibitors with reduced COPD risk, updated chest guidelines for stage 1-2 non-small cell lung cancer, and we'll wrap up with a cardiologist's perspective on the assessment of breathlessness. Let's get started. We start with a powerhouse paper published in the Lancet Respiratory Medicine. Tyler Pitre and colleagues conducted a systematic review and network meta-analysis comparing 3 preoxygenation strategies for patients in the ICU or ED requiring intubation: face mask, oxygen, high-flow nasal cannula, and non-invasive positive pressure ventilation. This study included 15 randomized controlled trials and over 3,400 critically ill adult patients. The goal? To determine which strategy best prevents hypoxemia during the high-stakes period of intubation. Let's break down the findings. Compared with standard face mask, oxygen, non-invasive positive pressure ventilation significantly reduced the risk of hypoxemia, with a relative risk of 0.51. High-flow nasal cannula also showed benefit in terms of reducing risk of hypoxemia over face mask oxygen, with a relative risk of 0.69. And when comparing non-invasive positive pressure ventilation directly to high-flow nasal cannula, the edge still goes to non-invasive positive pressure ventilation, with a relative risk of 0.73. Now, what about safety? Non-invasive positive pressure ventilation likely reduces serious adverse events compared to face mask oxygen, with a relative risk of 0.32. There's even a possible advantage over high-flow nasal cannula, though this comes with lower certainty. Interestingly, none of the strategies improved the odds of first-pass success or overall mortality. So what's the takeaway? If you're managing a high-risk intubation, especially in a patient with shunt physiology or severe hypoxemia, non-invasive positive pressure should be your go-to for preoxygenation, especially in obese patients or those with poor reserve. High-flow nasal cannula remains a viable option, particularly when non-invasive positive pressure ventilation setup is delayed or not tolerated. Next up, we shift gears to pediatric asthma, a population that often presents clinical conundrums when it comes to biologics. This systematic review from Vertgen et al., published in the European Respiratory Review, evaluated the safety profiles of 5 biologics used in pediatric asthma: omalizumab, mepolizumab, dupilumab, benralizumab, and tezepelumab. The analysis included 45 reports and 13 clinical trials. Importantly, 8 of those were placebo-controlled. The findings, well, they're mostly reassuring. The most common adverse events reported were headache, injection site reactions, upper respiratory tract infections, fever, pyrexia, urticaria. None of the studies revealed any new safety signals not already documented in product labels, even with up to 7 years of follow-up. One key limitation flagged was the small sample size of pediatric patients and inconsistent reporting of adverse events across trials. Plus, long-term outcomes remain uncertain, so vigilance is still warranted. So how do we apply this? If you're managing a child or adolescent with severe asthma, unresponsive to standard therapy, the data supports the continued use of biologics as a safe adjunct, provided there's good monitoring and informed shared decision-making. Let's turn our attention to a study that bridges cardiometabolic and pulmonary medicine. Published in the American Journal of Respiratory and Critical Care Medicine, this large, population-based cohort study examined whether SGLT2 inhibitors, already widely used in diabetes and heart failure, might also reduce complications in patients with COPD. Using Taiwan's National Health Insurance Research Database, researchers evaluated over 299,000 patients with coexisting type 2 diabetes and COPD between 2009 and 2020. After propensity score matching, they analysed 1,288 pairs of SGLT2 inhibitor users and non-users, focusing on a composite primary outcome that included hospitalisation for COPD, need for non-invasive or invasive ventilation, and all-cause mortality. Here's what they found. SGLT2 inhibitor use was associated with a 21% lower risk of the composite primary outcome, which was COPD exacerbation, cardiovascular diseases, and mortality. Specifically, users had a 52% lower risk of requiring non-invasive positive pressure ventilation, a 36% lower risk of all-cause mortality, and an 18% reduction in COPD-related hospitalizations. These effects were consistent across subgroup and dose-response analyses. So, what does this mean for clinical practice? While causality can't be established definitively from observational data, the findings suggest that SGLT2 inhibitors may offer pulmonary benefits in addition to their known cardiovascular and metabolic effects, especially for patients dealing with both diabetes and COPD. Future prospective trials will be needed to clarify their role in reducing COPD exacerbations and ventilator needs, but this is an intriguing step forward in integrated chronic disease management. Let's talk lung cancer. The American College of Chest Physicians just released their updated guidelines for the management of stage 1 and 2 non-small cell lung cancer, published in Chest. The guideline synthesizes findings from 578 studies and offers 17 evidence-based recommendations. Here are the major updates. For stage 1 non-small cell lung cancer patients with low or average operative risk, surgical resection remains the gold standard, with a strong preference for minimally invasive approaches over thoracotomy. Sublobar resection is now considered equivalent to lobectomy for tumours less than 2 centimetres in peripheral locations. Systematic mediastinal and hilar lymph node sampling or dissection is emphasised during surgical planning. Adjuvant chemotherapy, particularly when paired with checkpoint inhibitors, improves survival for stage 2 patients and even stage 1B if tumours are 3 centimetres or larger. For EGFR mutant non-small cell lung cancer, adjuvant targeted therapy like osimertinib improves overall survival in stage 1B and 2 disease. SBRT is now the preferred option for medically inoperable stage 1 patients. These updates reinforce a shift toward more nuanced, molecularly informed, and less invasive management strategies. And finally, let's take a step back and reflect on breathlessness, not just as a symptom, but as a shared diagnostic challenge between pulmonology and cardiology. In their review, Bowie and Fahey outline a cardiologist's framework for approaching dyspnea, emphasizing that diagnostic errors can arise when physicians attribute symptoms too quickly to one organ system over the other. They propose a structured evaluation involving 4 key domains: pattern of breathlessness, exertional orthopnea, cardiac imaging, echocardiography remains central, exercise testing, particularly CPET to unmask early cardiac dysfunction, invasive hemodynamics in select cases. Their message: pulmonary and cardiac teams must collaborate early, especially in patients with comorbidities like obesity or HFpEF, where dyspnea etiology may be multifactorial. It's a worthwhile read for anyone reassessing their approach to unexplained breathlessness. And that's a wrap for this week's episode of This Week in Pulmonary and Critical Care Medicine. If you found this summary helpful, consider subscribing and sharing it with colleagues who may benefit. We'll be back next week with more updates from the front line of respiratory and critical care research. Until then, stay curious and stay evidence-based. Take care, everyone.